Good evening, everyone. Welcome to this evening of orthopedic teaching. This session today is about radiology of the foot and ankle. It's part of our orthopedic X-ray interpretation course that we delivered on the 20th of August, and this is just a continuation of the course with an add-on lecture. We try to stay focused on the topic. We will try to finish early, so hopefully less than an hour. By 7 o'clock, you'll be finished. Very important always in all our sessions to be interactive. So please, if you have any questions, any doubts, please write them in the chat box, and we will not leave today until all your questions are answered. We'll ask you to fill a feedback form, and you will automatically get a certificate. And we will try, obviously, to make this recording available for you, obviously free of charge as part of your registration. My name is Firas Arnaout. I'll be hosting this event. And we're very proud to be hosting this for the first time ever on Middle. And I'm very honored that the speaker for our first Middle event is Nikki Evans, who is our colleague orthopedic surgeon. And she is one of the founders of Orthopedic Academy, and she's been an educator with us for a long time. And she's taken on today the topic of radiology of the foot and ankle. Just to warn you guys, there are polls questions, so please stay focused. Yeah, the polls are anonymous, so please give it your best shot, but stay focused with us throughout the presentation. Over to you, Nikki.
Okay, thanks very much, Firas, and welcome everyone. So what I'm going to do is just go through the radiology of the foot and ankle and maybe some common conditions, so you know what to look for when you're looking at x-rays of this part of the body. So if I start with some normal anatomy, so if we start with the ankle, this is a typical AP x-ray of an ankle. So we can see we've got the fibula down on the lateral side, we've got the distal tibia here, and there's a few things that you need to look at. So if you look at a true AP, you will have some overlap of the fibula on the tibia and a little bit of overlap of the fibula on the edge of the talus. So this saddle shape here is the talus, also known as the talar dome. And what we look at is we're going to look at, here is the ankle joint space along here and down here. Now on this AP view, we're not going to comment on that space. We're going to look at a mortise view for that. But what we can see on this view is we've got the lateral process of the talus down here. We've got the distal end of the tibia, or the fibula, sorry, also known as the lateral malleolus. On the medial side, we have the medial malleolus, which is the distal end of the tibia. And then we've got this part of the tibia here, which is the distal end of the tibia, but it's also given some other names, particularly when we talk about fractures. So it can be known as the tibial plafond, because it's flat, or tibial pilon. Again, just describing the way that it sits in the mortise of the ankle joint. So if we then move on to a lateral view, there's a couple of things to look at on this. So if you have a true lateral view, what you should be able to see is some joint space through here. Now, as in this x-ray, we've got a double shadow for the talus here and here. So the medial and the lateral margins of the talar dome are overlapped. We've got the fibula, which is here, and it's projected over the tibia. But if you can just see the margin come down there, and then this bit at the back. So this, which says 12, is actually the back of the tibia. It should be extended a little bit to here, which is the overlap of the fibula on the distal tibia. We're going to look at the talus, in particular the talar dome, which comes around here. We've got this indentation here, which is the talar neck. And then we're going to come on to the anterior process. This kind of rectangular bone here is the navicular. This one here is the calcaneus. And the joint below the talus, above the calcaneus, this is the subtalar joint. The joint that we're seeing here is the talonavicular joint. And we go further down, this is going to be one of the intermetatarsal joints. At the back here of the talus, sometimes you can see a little projection, which is the posterior talus, posterior process of the talus. And that can sometimes be fractured. And really, it's just symptomatic treatment for that. So let's have a look. This is a mortise view. And the way that this is taken is with 15 to 20 degrees of internal rotation. So what you're going to see on here, as opposed to the AP view, is you won't have any overlap of the fibula on the talus. And the reason that we do this view is so that we can look at the space that constitutes the ankle joint. So you've got the medial malleolus. This part here is known as the medial clear space. You've got the area between the tibial plafond and the talar dome across the middle there. And then because we've got this particular view, we can also see the lateral clear space down the side. Now, in the absence of any ligamentous injury, then this clear space should be symmetrical on all sides. There is always a little bit of overlap between the tibia and the fibula here. And this is the tibio-talar ligaments, which constitutes an anterior, a posterior, and a middle component, also known as the ankle syndesmosis. Okay, we've got lateral ligaments from the distal end of the fibula to the talus, and also to the calcaneum. So that's a lateral ligament complex. And on the medial side, we have a deep and a superficial deltoid ligament. Okay, you might see somewhere that, you know, if this space is greater than 5 millimeters, it indicates an injury. Well, yeah, it's possible. But what you're looking at is the symmetry of this, plus some other features that we'll have a look at when we come to look at ankle fractures. Now, the foot can be quite complicated because it's got lots and lots of bones. But there's a few things that you need to look at. Here we're looking at an oblique and an AP. So you're going to look for this rounded bit here, which is going to be the anterior process of the talus. And that is going to articulate with this kind of rectangle here, which is the navicular. And here we see it on this side. On the lateral side at this level, you've got the cuboid, which is like a cube. That's why it's called a cuboid. So that's on the lateral side. And then just distal to that, you've got the cuneiforms, which you can really only see the first cuneiform on this view. But if you look at the slightly oblique view, you can see the medial, the middle, and the lateral cuneiforms. And the importance of these is when we come to look at Lisfranc injuries, is that if you see how the medial one projects up like this, and then there's kind of a little slot for the base of the second metatarsal to slot into, and then you go along the lateral down to the cuboid. All right, and there's an important ligament that goes from the medial cuneiform to the base of the second metatarsal, which holds this all in place, and it holds it in place in 3 planes. So if you think about a Roman arch, that's how it all slots in, and it maintains the arches of the foot as well as the overall alignment of the bones. And we'll have a look at that when we come to it later. So then we come to the metatarsals. Here we go. The first one's easy to recognize because it's the biggest. Then we've got second, third, fourth, fifth. And they're going to go on to the phalanges of the toes. So the toe, like the thumb, you've got a proximal and a distal phalanx. And then you've got proximal, middle, and distal for all of your lesser toes. And there we go. There they all are. Okay. Sometimes it can be very difficult to see a fracture in the foot, which is why we use CT scans a lot of the time to give us a clearer anatomy. Because if we look at the lateral of the foot's quite good if you're looking at the ankle joint like we see. Here is one with a posterior process of the talus here. We've got our talar dome, anterior process of the talus. We've got our calcaneus here. And then we're going to look at the navicular, which is here. And then we're going to move on to the middle cuneiform. And then we're going to go on. And if you look at this, it's quite difficult to see which metatarsal is which, and the same with the phalanges. But what you can sometimes see on a lateral view is if you've got a fractured metatarsal where there's a spike of bone projecting posteriorly or anteriorly, you can see that. If there's any disruption of the talonavicular joint or the subtalar joint, if there's a Lisfranc fracture dislocation, which involves the tarso-metatarsal joints of the foot, what you might see, and we've got an x-ray of it soon, is this will be sitting asymmetrical. The calcaneus, which is this bone, we sometimes get this axial view of the calcaneus, particularly when we're looking for fractures. And it's done as a kind of axial view in order to see this kind of outline of the actual heel bone itself. And you can sometimes see fractures through this area. If we want to look closer at the important parts, which would be the subtalar joint and the calcaneocuboid joint, often we use a CT to give us a better idea of what's happening there. Okay, so we've had a look at some normal x-rays. Let's have a look at some fractures. So ankle fractures are really common. And there's a few components to them. And there's a spectrum of disorder. And it goes from, you know, a mild ankle sprain, which would be usually a tearing of the calcaneofibular ligament or the anterior talofibular ligament, to something really nasty, also known as a tibial pilon fracture. Okay, so as well as the bones, we need to think about the ligaments around the ankle joint. The big one is the inferior tibiofibular ligament. All right, so as I said earlier, there's an anterior, a middle, and a posterior part to this. The posterior part of it is the strongest, and often you can pull off the posterior part of the tibia if that ligament is very strong. So we're going to look at the ankle. This is also known as the syndesmosis. Okay. This is important when we start to look at classification of fibular fractures. So we're going to keep an eye out for this area here. The interosseous ligament runs from above the syndesmosis, between the tibia and fibula, almost all the way up to the neck of the fibula. Okay. Now, if you have something called a Maisonneurve injury, this ligament is torn. And so although the x-rays themselves don't look very exciting, the fact that you've got the whole of this ligament torn makes the ankle joint quite unstable. And it's a fairly big injury that needs to be addressed, which is why clinical examination of these patients goes in conjunction with interpreting the x-rays. Here we have the medial malleolus. We've got a superficial and a deep deltoid ligament. They attach to the talus, and they're going to maintain our talus within our ankle mortise, if you like. Okay, so there's some ligaments. Let's have a look. So this is the Weber classification of ankle fractures. It's a pretty simple classification system, and it directs your treatment. So this is the one that we tend to use. And if we look at it, it's quite simple. It's all based on the fibula. Here's the syndesmosis, and the rule is below the syndesmosis is an A. At the level of the syndesmosis is a B, and above the level of the syndesmosis is a C. Now, when we say the level of the fracture, what we mean is the most distal part of the fracture. So if you've got a fracture line that's starting up here, but it comes down to here, that would be a B. All right. So normally we look at the diagrams. We've got our syndesmosis, our lateral ligaments, and our deltoid ligament here. It's normal. It all looks nice. There's a good space. In a Weber A fracture, we accept that the ligaments are probably intact because your fracture goes through here. So it's below your syndesmosis. It's gone through the bone rather than tearing your lateral ligaments, and there's no reason the medial side should be injured. If we go with a B, these are the borderline ones because Sometimes they disrupt the syndesmosis and sometimes they don't. So we have to make a judgment call based on clinical findings and other radiological findings, and we will have a look at some of those. The question is whether there is the integrity of the syndesmosis is intact, thereby stabilizing the tibia and fibula, and whether the deltoid ligament is intact as well. So these are the ones that you need to look at closely. The Weber C, relatively straightforward because they're above the syndesmosis. The syndesmosis is gone. They can be quite dramatic. The ankle might be dislocated. On this view, you've got a fracture of the medial malleolus here, but alternatively, you could have no fracture and disrupt your superficial and deep deltoid ligaments. These are nearly always unstable and nearly always need an operation. So A, we don't need to operate on. C, we do need to operate on. And the ones in the middle, we have to make a clinical judgment. So let's have a look. So this is a Weber A fracture, okay? They're usually transverse. So here's one here. Sometimes there's a medial malleolus fracture, usually a transverse at the same level. And the ligaments are usually intact. If you look at the mortise view, here it is. Our clear space is fine. And they're usually stable. So we can treat them, depending on how much pain the patient's in, we can treat them in a walking boot, or we might put them in a backside for a couple of weeks to let the pain settle down and then let them go into a boot and start walking. And as we can see, our syndesmosis is going to be in this area here. So we're below, we're transverse, our joint space looks fine, our ligaments look intact. We don't need to operate on this patient. Let's have a look at a B. Okay. So these are the typical kind of configuration that you see with a B fracture. If you look, the fracture line goes into this area, which is the syndesmosis. And if we look at the joint space around here, so we know this is a mortise because there's no overlap between the distal tibia and the talus. What we can see is that there's probably a little bit of displacement on the fracture site itself, but what's a little bit more worrying is if we look at the gap on this side compared to the gap here, it seems to be wider. There's also this little flake of bone here, which could indicate a rupture of the deltoid ligament with an avulsion of a small piece of bone. So this is one that we are going to examine carefully. We may do some more x-rays, or we may decide on clinical examination, this is one that should have fixation. Here is another one. Now, this one is slightly different. So it looks like the same kind of configuration here. But if we look at the distance between the tibia and the fibula on this, that relationship appears to be preserved, whereas on this one, it appears to be a bit wider. So this one also has no increased opening on the medial side. This one is very likely to be stable, but again, we're going to assess it clinically, looking for medial tenderness, medial bruising, and we'll probably do some stress views. On the lateral, this doesn't give you a lot of information, but you can see that the ankle joint is located. And if you look at the overlapping fibula, you can just see the tip of the fracture there, exiting posteriorly, which is what they normally do. So we move on to a Weber C. So this is a Weber C fracture above the level of the syndesmosis. And if we look at the distance between the tibia and the fibula, it's wide. Okay, it's that syndesmosis. All three bundles of it has gone. These bones should not be that far apart. There's probably a little fragment of bone there, which is probably off the back of the tibia, which often happens. So your fibular fracture is above the level of the syndesmosis. Here it is. It's a Weber C type fracture. You've got widening of the ankle syndesmosis, also known as diastasis, which means the two bones have come apart. And in this one, you've also got a fracture of the medial malleolus. And then if it couldn't get any worse, the ankle is dislocated. So here is the distal end of the tibia with its nice dome, and here is the talar dome, which should be sitting underneath here. So this is a fracture dislocation of the ankle joint, and this needs to be reduced. I mean, we wouldn't expect you to be able to do a closed reduction to reduce the whole fracture, but what we want to do is get the ankle located and take the pressure off the skin on the medial side. This ankle will look very deformed and it will be very painful. So we're going to look at another view now, which is something called a Maisonneurve fracture. So these are the ones, when I talked about that interosseous membrane that goes between the tibia and the fibula for the whole length, how a simple x-ray could lead you down a false path. So if we were to just x-ray the ankle here, you might say, oh, well, it's overlapping a bit there. It looks a little bit wide, but I'm not sure. And yes, there's a massive clear space on here. So there's definitely something going on. But, oh, I can't see a fibular fracture. Well, the answer is you need to look further up. So this is an x-ray of the knee, a lateral view. And you can see a fracture here through the proximal fibula. The force of this injury, which is usually a fairly significant twisting injury, for example, somebody falling down a flight of stairs, and the fracture has gone through the proximal fibula all the way down the interosseous ligament, through the syndesmosis, and out through the medial ligaments, namely the superficial and deep deltoid ligaments. So this is something that we need to fix. We don't need to fix the fibular fracture, but what we do need to do is reduce this, get some kind of fixation across the syndesmosis to reconstruct this normal relationship. And when we do that, this will often reduce, and we don't need to do anything else. Sometimes if the deltoid ligament has been torn and stuck inside this gap, when we try to reduce it from this side, we can't do it. So we have to open the medial side and actually pull out the deltoid ligament. Often the deep is gone and the superficial can remain intact. If you've got a superficial and you reconstitute the syndesmosis, then you usually don't have to do anything else to the deep, but you're going to screen it and make sure it's stable. You may have heard of the AO classification, the Legg-Hansen classification. I mean, I don't think it's particularly useful because the Weber classification is simple and it guides treatment. And if you talk about it, everybody knows what you're talking about. The Legg-Hansen, it's nice because it explains how you get the different patterns of injury. Basically, as you supinate and adduct, you go lateral ligament or lateral malleolus, and then you go round till you get to the medial side. And again, it's as you increase the force through the ankle, so a ligament or a bone will be injured. And it's nice for understanding your mechanism, but it doesn't really tell you how to fix it. And again, the AO classification, it's good for writing papers, but it doesn't really help us with a lot of these ankle fractures, because if you look at the AO classification, it's either extra-articular, partial articular, or intra-articular, you know, and most of them are going to be in the type A, so that doesn't really help either. So what do we do? So we've got the Weber A, that's usually going to be a boot and weight bearing is tolerated. We've got the C, which is usually going to be surgery and non-weight bearing. And then we've got the Weber Bs, and we need to determine whether they're stable or unstable. And you can do a stress view or a weight bearing view. And what you're looking for is widening of the medial side of the joint, which would indicate a more unstable fracture pattern and probably surgical intervention. So this is a typical stress view. Now, this is a Weber C because you can see the fracture up here. So I'm not sure why they've done a stress view on this, but there you go. And what this is what we would do in the operating theatre with the patient asleep. I think this would probably be too painful to do in the x-ray department, but you can see the examiner's hand here, and what you're doing is you're putting a stress of external rotation on that ankle joint to see whether the medial side opens up. And in this case, it does. If you compare that distance to this distance, you can see it's a lot wider. So this would be unstable. Here's a Weber B. This is a different type of stress view. So in this one, you put the patient on their side and you let gravity hold to see whether the talus drops with the distal end of the fibula. And if it does, you'll have increased opening on this side. And I'd say this one's not too bad. I don't think there's a lot of opening on that side. It hasn't moved a lot. So I'd say this one is probably stable. And the last one you can do is you can ask the patient to weight bear. And when they weight bear, if the tibia and the fibula have got an injury to the syndesmosis, then what you'll find is on weight bearing, there will be an increase in the gap between the tibia and the fibula. And you may see increased medial joint space, but you're looking at the gap between the two of them. And in fact, I had a patient in clinic last Tuesday that I was pretty sure it was like this. It looked relatively unstable, but I got some weight bearing views after a week and it actually opened up a little bit. So we are going to go ahead and fix that. Even though clinically it was difficult because she didn't have any particular medial tenderness or medial bruising, but the stress view was quite remarkable, just the weight bearing, and it showed that the ankle mortise, the ankle joint, opened up quite a lot. So they are useful. How do we fix them? So here we go. We've got a Weber C fracture. A Weber B fracture down here. We've also got a medial malleolus fracture. Now, if we think about this, if this is where it's supposed to be, then we've definitely got increased medial space there. And you haven't disrupted the deltoid ligaments, but you've fractured the medial malleolus. So this is going to be unstable and we are going to fix it. So how do we fix it? The first thing we do is we reduce the fibula and put a plate on it. Here's our plate. All right. The reason I put this in is because patients often look at this x-ray and say, oh, my screw's fallen out, which is this one here. But that's not what we do. So if you have to try and imagine this in a 3D, but if you reduce the fracture and the fracture line's going this way, what we do is we put a lag screw to hold the fracture in place, which goes at a different angle. Then we put a plate down the outside and we fix it. We fix the medial malleolus on this side, usually with 2 screws through there. And then we test the stability of the syndesmosis. And if there's any concern, then we put what's called a diastasis screw in, which is one that goes from the fibula into the tibia. Some people use 2. Some people go through to the other side of the tibia. Some people don't. There's no real evidence to suggest what you need to do either way, provided you get this joint reduced. We keep them non-weight bearing for at least 6 weeks until the fracture's healed. We used to take out the syndesmosis screws routinely. Again, we don't do that anymore. Sometimes they break, but they don't tend to cause any problems. But we do take them out if they're causing any symptoms. So, you know, I've got a patient that is about 6 months after having fixation for a fracture very similar to this. He does a lot of hiking. And what he can feel is clicking and grinding. And that's probably because the screw's not broken yet. But it may be that holding these 2 bones together and then allowing your foot to do dorsiflexion and plantar flexion if you're climbing up and down hills might give you some restriction and some discomfort. So he's someone that we are going to remove the screw for. But it's usually on a case-by-case basis. So the other end of the spectrum are these tibial plafond fractures, tibial pilon fractures, distal tibia fractures. They're usually quite bad. The classification doesn't really help you because we almost invariably end up getting a CT scan to see the extent of the articular surface involvement. And if you look at this, you can have just simple fragments, or you can have ones that look a lot worse than this in multiple fragments. And the principles of management for these are to manage the soft tissue because they're usually very, very swollen. Manage the soft tissues. You might need to put an external fixator on, and then you want to try and reconstruct the joint surface as much as you can, and then deal with it later. But that's kind of beyond the scope of this lecture. It's just there to show you what a really bad ankle fracture looks like. Okay, so here's the first question. I've got this x-ray here. We've got a 23-year-old female who falls down the stairs and complains of a painful ankle. So your x-ray shows, and you've got some options: a fibula fracture, a tibia fracture, a Lisfranc injury, talar shift prompting further investigation, or is it a normal x-ray? So what we're looking at is an x-ray of the ankle. We can see here's the distal fibula. There's no fracture here. We're looking at the distal tibia. Can't see a fracture there. Lisfranc injury is in the foot that we'll come to. We're looking at the medial clear space here and comparing it to this one, and it's massively abnormal. So if you remember, and if we look at the distance between the tibia and the fibula here, there should be some overlap. So this is one of those things that we need to look at further investigation. And what do we need to look for? The proximal fibular fracture. This is the Maisonneurve injury, and this is the trap that you fall into if you don't examine the patient and x-ray the whole of the tibia and fibula. So the correct answer is talar shift, prompting further investigation. Okay, we'll move on. So I'm just going to talk briefly about these because the fractures was the main one I wanted to talk about. But ankle arthritis, here's some ankle arthritis. It's got the typical features of arthritis. You've got joint space narrowing, sclerosis, subchondral cysts, and osteophytes. So we've got some osteophytes happening around here and around here. So that would be ankle osteoarthritis. Charcot ankle. So Charcot disease is usually the end result of diabetes in the Western world. And the classic features of Charcot are that you get fragmentation, bone destruction, dislocations, and a very abnormal looking x-ray. So if we look here, you know, our distal tibia joint's more or less gone. It's collapsed. There's no end of the fibula. And there's all these kind of areas of where the bone's fragmented. Could this be infection? Yes. Could it be an end stage of rheumatoid? Possibly. But when you see this volume of joint destruction, it's usually Charcot or infection. Right, let's have a quick look at pediatric ankle fractures. So I haven't gone through the Salter-Harris classification because it was covered in one of the other lectures. So that's why I haven't gone through it. But if we look at this one, we've got a distal fibular growth plate. We've got a distal tibia growth plate. Our fibula fracture is up here. So we've got a distal fibula fracture. And if we look at the tibia, we've got the epiphysis here with the medial malleolus. We've got this metatarsal fragment here, and our fracture line has gone through here and through here. And here's the other fragment. So the ankle has gone into valgus. You have a metatarsal triangle of bone attached to the epiphysis, which makes it a Salter-Harris 2. And the worrying thing about this injury is the amount of deformity and whether this is going to cause pressure on the skin on the medial side. So this needs to be reduced. So a couple of fractures that are particular to the pediatric population, and the first one is the triplane fracture, which is usually happens in round about 12, 13-year-olds, and it's because of the way that the growth plate fuses. So you don't get this kind of appearance in the younger children or in the older children. It's only really this particular age group. And it's called a triplane because the fracture is in 3 planes. So you have, on the lateral, you have the fracture, which is metatarsal, which is similar to a Salter-Harris 2. So you've got a triangle of bone. You have a fracture below the growth plate in this plane, which is here, which is similar to a Salter-Harris 3. And then you have the other fracture that goes through the growth plate. So you're going through the tibia, through the growth plate, and out through the epiphysis. And the best way to visualize these is on a CT scan. So if you look at the CT scan here, you can see this part, the epiphyseal part of the fracture, is there. So you've got a gap about 3.3 millimeters there. You've got this component of the fracture, which again, it's a Salter-Harris 2. You've got your little fragment of bone there, and it's gone through in this plane. And then you've got this other fracture that goes actually through the growth plate. So these usually, depending on what they're like, you usually need to reduce them. Usually because if you have a step or a gap in the joint surface, you want to try and correct that. So if it's only 1 or 1 to 2 millimeters, you may be able to get away with not operating, but otherwise we need to reduce that to preserve the articular surface. So as the growth plate continues to fuse, you get this fracture, which is known as a Tillaux fracture. And it's this component here. So because the growth plate, so we're looking at the growth plate here, the growth plate fuses from medial, which is here, and then it goes around the back, posterior, around here. And the last part to fuse is the anterolateral part of the distal tibia. So what happens in a Tillaux fracture is you've got more fusion of the growth plate than you do in the 13-year-olds. So you don't get the triplane, but what you get is this fragment of bone being pulled off by the ankle syndesmotic ligaments there. So you get this chunk of bone. So in an adult, you'd get a syndesmosis injury. In a younger child, you'd get probably a Salter-Harris 2 type fracture. But in this age group, which is usually a little bit older than the triplanes, you get this Tillaux fracture. When do we need to operate on them? When there's a step or a gap in the joint surface of 2 millimeters or more. And again, CT scan will give you more information. So here's the next question. We've got a 7-year-old boy with an injury to his ankle during football. What does this x-ray show? Does it show a Tillaux fracture, a triplane fracture, a Salter-Harris 1 fracture of the distal fibula, a Salter-Harris 3 fracture of the distal tibia, or a Salter-Harris 2 fracture of the distal tibia and a fracture of the fibula? So E is the correct answer. So why is it not a Tillaux or a triplane? Well, the kid's 7. So if we remember, the triplane is round about 12, 13, and Tillaux is round about 13, 14. Because of the nature of the way that the growth plate fuses. This kid's 7, so his growth plates are wide open. So that rules out A and B. Nobody picked C, which is great because it isn't. Salter-Harris 3 fracture of the distal tibia. So Salter-Harris 3 is one that is through the epiphysis rather than the actual metaphysis. It's through the epiphysis, through this part. So it's not that one. So it's a Salter-Harris 2 because we have this metaphyseal fragment of the distal tibia. So it's a Salter-Harris 2 fracture of the distal tibia. And we also have a fracture of the fibula up here. So well done, everybody that got it right. Okay, so the next ones can be quite complicated. I'm going to try and make it simple and don't overthink them too much because the talus and the calcaneus and a lot of the foot things, we will do a CT scan to get the, to be 100% sure of what's going on. And that's beyond the scope of this lecture. We're just going to talk about x-rays. So that's what you might come across in the emergency department. So let's have a quick look. Right. Now, the talus is a complicated bone. All right. It's difficult to see clearly in plain x-rays. CT is good for fractures. An MRI scan is good if you're looking for something else like avascular necrosis or osteochondral lesions. So it sits in here and it sits in there. And it's got 3 joints. It's got the tibio-talar joint, which is one. It's got the subtalar joint, which is the joint between the talus and the calcaneus. And it's got the talonavicular joint, which is the joint between the talus and the navicular. If you remember, the navicular is the rectangle, and the cuboid is on the lateral side, and that's the cube one. And we'll look at that in a sec. All right. Why are we bothered about the talus? Okay, so the problem with the talus is its blood supply. And it's got this, it's a bit like the scaphoid. It's one of those bones that's got a blood supply that if you knock off part of it, then you get avascular necrosis. And so if you have a fracture through the talar neck and you take out this arterial supply, you're losing the blood supply to the anterior part of the talar dome and further down here, because the supply from your posterior tibial is only going to go so far. So the talar neck fractures are the ones that we get a little bit excited about. And here it is. Okay. Talus, tibia and fibula, calcaneus, subtalar joint, talonavicular joint here. There we go. All right. Let's have a look at some of these. So this is the classification system. I don't expect you to know the classification system, but it helps to understand why these can be concerning, let's say. So we're talking about the talar neck here, so that little indentation. So if we've got one that's undisplaced, chances are the blood supply is all right. So the risk of getting a vascular necrosis is between 0 and 13%. A type 2 is where we have a fracture through the neck and the subtalar joint is dislocated, slightly higher risk of avascular necrosis. Now we get on to the more exciting ones. So the type 3 has got a subtalar and a tibiotalar dislocation. And often with these, the talus, this part of the talus ends up either open on the road or at least out the back on the x-rays. That's a type 3. And then the type 4, which is subtalar, tibiotalar, and talonavicular dislocation. And again, this fragment can be extruded out the back. This fragment can be extruded out the front. And these have got a much higher risk of avascular necrosis. That says type 2 there. I'm sorry about that. I should say type 3. So 1, 2, 3, 4. So 1 is not too bad. 4 is terrible. And the other 2 are in between. Let's have a look at some x-rays. Right. So here we go. Here's a type 4. Here's the distal end of the tibia. Here's the calcaneus. Here's the navicular. And we've got the talus fractured and popping out the front. And if you look at the skin line here, this is going to be open. All right. It's a type 4. This is going to have a bad outcome. Here is a type 3. So we've got a fracture through the talar neck. There it is. We've got subtalar joint disruption and we've got tibiotalar disruption as well. And you can see the talar dome is actually kind of spun round where it is. Here's a type 1. So if we look at this one, we've got a fracture through the neck, but our tibiotalar joint's okay. Our subtalar joint is probably okay. And our talonavicular joint is okay. Here's another one. This is a type 2. So we've got a fracture through the talar neck and we've got disruption of the subtalar joint. The talonavicular joint is okay. And this one, you can't always trust this view because it looks like the tibiotalar joint is in joint, but it can't be because where the anterior process of the talus is out here, it's actually come out and spun around. So the tibiotalar joint must have gone, subtalar joint must have gone, and the talonavicular joint must have gone. And the thing is with these, we're going to do a CT scan. If you've got this, you're going to treat it as an open fracture. And you're probably going to try and reduce it. But we're going to get a CT scan to identify where all the fragments are and what we've got to work with. So something simple. This is another type of talus fractures, and it's just the lateral process of the talus. I don't know about this country. In Australia, we used to call this a snowboarder's fracture because snowboarders used to get it. You don't need to do anything for it. Treat it non-operatively, symptomatic, maybe a boot if they've got a lot of pain and swelling over their ankle. Talar dome lesions, again, it's only here because you might hear people talk about it. You can have medial and lateral. The lateral ones are the more likely to be traumatic. So somebody that's had an ankle sprain that just hasn't got any better might have a talar dome lesion. The medial side ones tend to be related to more chronic conditions. And although you can see them on this x-ray, sometimes you can't. So the method of choice is an MRI scan. And what you can see is a loose fragment of cartilage with a piece of bone missing there, because what's happened is with avascular necrosis, you get collapse of the underlying bone. The cartilage is over the top, and then with time and wear and tear, the cartilage will collapse as well. Tarsal coalition happens in kids. Usually the kids present in adolescence with recurrent ankle sprains. Just so you can see it on an x-ray, there's two types. There is the this one, which is the talar calcaneus, and it's a C shape here. So what you've got is an abnormal connection between the talus and the calcaneus. And then you've got this other type, which is supposed to look like an anteater. And it's a connection between the calcaneus and the navicular. And it can either be purely bone, purely cartilaginous, or it can have like a little synchondrosis between it. Again, treatment is symptomatic. MRI scan will give you a better idea of what's actually happening. But in case you come along something and someone says, oh, it's a coalition, it's got a C shape or it's got an anteater, that's what it is. Okay, so here's another question. We've got a 38-year-old male involved in a road traffic accident. Here's his x-ray. So what should we do? Should we put him in a back slab and send him to fracture clinic in 7 days? Shall we assess his neurovascular status and advise trauma and orthopedics? Does this have an AVN rate of 10%? Is the subtalar joint reduced? It requires an urgent CT scan. So think about what you would do when this patient rocks up and you're the first doctor to see him. What's going to be your first thought? So back slab and fracture clinic follow up with 7 days. Oh God, no. Please don't do that. It has been done, but I'd probably say not in this case. So if we look at the x-rays, here's the distal tibia. Where's the talus? Oh my God, it's over here. So tibia talar's gone. Subtalar joint has gone because it's over here. And here's a navicular. So the talonavicular joint is also disrupted. So that puts us into a Hawkins type 4, which is the worst type, which has an AVN rate of 70 to 100%. So the subtalar joint is reduced? Absolutely not. It's gone. Urgent CT scan, it probably does, but your first thing that you're going to do is assess the neurovascular status and advise trauma and orthopedics, because this is something that needs urgent reduction in the operating theatres. And even if, you know, it looks open, we get this to theatre, we reduce it, we can assess it. Even if we do temporary fixation, wash it out, then we can get a CT scan later and fix it at a later stage, but it needs to be reduced. You've got 3 joints dislocated in the ankle. Your guy's 38. You want to get onto this as soon as you can, and you want to know if there's any nerve or vessel compromise. So well done. Here we go. Here's another question for you. You've got a 12-year-old male, history of recurrent ankle sprains. Here's his x-ray. I've even got some nice helpful arrows in there. What's this? Is it a talar neck fracture, a tarsal coalition, a calcaneus fracture, a Lisfranc injury, or a hallux valgus? This is a tarsal coalition. So we're looking at the C shape. Talar neck fracture? No, not really. Tarsal coalition, yep. And we've got this nice C shape. We've got all the arrows pointing to it. Calcaneal fracture? Probably not. Calcaneus looks okay. Lisfranc injury? we haven't covered that yet, so it's not going to be that. And a hallux valgus, we haven't gone into the big toe. And also, he's got a history of recurrent ankle sprains. He's not a motorcycle accident or a fall from a height. So the age, the history of ankle sprains, the X-ray findings would be consistent with a tarsal coalition. Calcaneus fractures, again, one of those things that we usually get a CT scan to better identify. It's a huge range of them, usually a fall from a height, sometimes bilateral, sometimes associated with vertebral fractures. Typical ones are quite fragmented, go into the subtalar joint. Here's that axial view that we talked about earlier. You can see it's gone through here and it's gone through here, and a CT scan will give you a better idea of what you're dealing with. The old Essex Lopresti type classification classified them as two. One was intra-articular with joint depression, and the second one was a tongue type where the Achilles tendon had pulled off a beak of the calcaneus back. And you do sometimes see them, and they're relatively easy to fix, but we usually CT them anyway to make sure the subtalar joint's intact. Here's some more. So here's one going through here. So this is probably, you know, the kind that it's difficult to see. This is why we CT scan them, but the subtalar joint might be all right there. It may just be this part that's lifted up, and it's possible we'll be able to treat that non-operatively or just with a couple of cannulated screws. The main thing about calcaneus fractures is to get them elevated and get the swelling down and make sure they don't have any other injuries. And then we can address the calcaneus fracture itself. Tarsal fractures, okay. Again, you wouldn't be expected to know a lot of this. It's kind of just for interest. So let's have a look at some things, some pitfalls. So this is the first one. This is the accessory navicular, okay. Why? Well, here's the navicular, this nice rectangle. And here's this. Why is this not a fracture? Well, it's in the tendon. It's got smooth edges. There's no soft tissue swelling. And that's the place where you can get an accessory navicular, and it doesn't normally need anything. Often you see patients with ankle sprains and they have some accessory naviculars or little bits all over the place, and you think it's a fracture, but it isn't always. And the clue here is the smooth rounded edges, and it's in the line of the tib post tendon. So that is an accessory navicular. Let's look at a fractured navicular. Here's one. Here's a nice rectangle bone. Here's the talus, and we've got a fracture through the middle of it there. Sometimes these can be undisplaced. Sometimes they can be open, and usually we can treat them operatively or non-operatively. Often it's operatively, and we just get some fixation across here. Cuboid fractures. Remember, the cuboid's on the lateral side, articulates with the calcaneus. Here's a fracture through the cuboid here. And here's another type of cuboid fracture, which is a small avulsion fracture at the base here. So peroneus brevis attaches here. So if you get a forced inversion injury to your ankle, you could pull off that little fragment there. And again, you don't need to operate on this, but you do need to protect them and treat them symptomatically. Okay, next question. 12-year-old. Inversion injury to the ankle. Here it is. What are we looking at? We're looking at an accessory navicular, a fractured navicular, a fractured talus, a fractured cuboid, or a Lisfranc injury. Accessory navicular, it's the X-ray that I showed before. It's got smooth round edges. Here's the navicular. It looks okay. It's in the line of the tib post tendon. You know, it's not the best X-ray of the talus. You can't see the cuboid because it's on the opposite side, and it's not a Lisfranc injury. So here's the Lisfranc. These are right and left feet compared. If we look at this line here. So we're looking between the medial cuneiform and where the base of the second metatarsal slots in next to that. And if we look here, there's a straight line. We look on this side, there's an increase in the gap. Okay. And if we look between the medial cuneiform and the base of the second metatarsal, there's an increase in this gap here. That is the basics of a Lisfranc injury, and here's the diagrammatic representation of it. Now, there's lots of different configurations of this, but that is the mainstay of the Lisfranc. So let's look at some x-rays of it. So sometimes on the lateral, if that ligament's gone, you can see here's your navicular, and you can see that your metatarsals have subluxed off the top. And here's another version of it. So here's your medial cuneiform, and look where your first metatarsal is. It should be over here, but it's shifted all the way on. So the whole of the tarso-metatarsal joints and ligaments have all moved to the side. This is a very nasty injury. And not only will you need to reconstruct that ligament, but you'll probably need to put some kind of fixation in to hold the rest of the tarsal bones back to the midfoot. Metatarsal stress fracture. So typically somebody that's been on the feet, runners, soldiers, you might not see anything on the first x-rays. You'll only start to see it when the fracture starts to heal, and you'll see this kind of callus formation, and there it is a little bit more. So 3 weeks later you might start to see callus. Treatment, again, the treatment is just symptomatically. You just need to think about it if somebody presents with that history. Rheumatoid foot, we're coming to the end now. Rheumatoid foot, so rheumatoid disease destroys the joints, synovitis, destroys the tendons and the ligaments, and you get progressive subluxation and dislocation. And that's what's happened here. Your MTP joints are all dislocating through there. And that's what happens in the hands as well in rheumatoid. Diabetic foot. So we talked about the Charcot ankle earlier on. Here's another one. You get fragmentation, dislocation, subluxation in the midfoot. So you get these abnormal appearances. You get this kind of rocker bottom appearance. You get ulcers. And if you look at a diabetic foot x-ray, you can see this patient's had amputation of his big toe, amputation of the little toe. He hasn't got very many midfoot changes on there, to be honest. But you'd be looking for that kind of appearance. Okay. And the last question, if we can, we've got a foot x-ray. There you go. Does it show fragmentation, dislocations, osteolysis, fractures, or all of the above?
So this x-ray is 42% got the correct answer. It's showing all of the above. There is fragmentation. As you can see, the bone is fragmented, metatarsals and metatarsal bones. There are dislocations and loss of normal alignment of the bones, loss of the joint, normal joints. Osteolysis, as well as the bone has clearly been dissolved in multiple places, but particularly around the bases of the metatarsals and on the metatarsal bones, and multiple fractures because the bone is fragmented, it's dissolved, so it's prone to fracture. So it has fractured. So well done, guys. Well done, everyone. That's great. So that was the last slide of this evening, and that was the last question. So on behalf of the Orthopedic Academy and Nikki, who we suddenly lost, I would like to thank you all for attending.